I think the remarkable activity of this ADC is now confirmed in the first-line metastatic setting in combination with Pertuzumab. Of course, we're all interested to see what the T-DXd alone arm is going to show. We know this therapy has been shown to be effective in more heavily pretreated HER2-positive disease. That's how it was first approved, then compared against T-DM1 in the second-line setting in DB03, and now seeing really remarkable PFS of over 40 months, as you pointed out. I think for our patients that develop recurrence shortly after completion of adjuvant therapy, those with a heavy burden of visceral disease, very symptomatic, those patients that have CNS disease at presentation, and it was debated in the past that whether these larger antibody drug conjugates penetrate the CNS, and now I think it's pretty clear that these drugs are very active, specifically T-DXd. Those clinical factors are factors that I would use to make the decision of who to give this therapy to in the first-line setting. That being said, I do think that there are still patients who may be very well served with THP in the first-line setting. And we all have these patients who present with lower burden disease, de novo disease. And as you point out, what's very attractive is we often give chemotherapy as sort of an induction time period for a certain number of cycles. And then many patients do very well on trastuzumab and pertuzumab maintenance. And of course, now we have the patina data and the HER2-CLIMO5 data to support maintenance approaches. So it's a real conundrum, right? What are we going to do in terms of the newly diagnosed patient? Does everyone need T-DXd pertuzumab? What we really need here is a biomarker, right? Because hindsight is 20/20, but wouldn't it be great to know upfront who those patients are, those 25% of patients that at 1 year are progressing on the Cleopatra regimen, that sharp part of the curve, and conversely, who are the patients on the tail of the curve who at 8 years are doing really well? If we knew who those patients were upfront, we would be able to tailor our treatments. Right now, I think we're left with making that decision based on clinical factors, as I mentioned.
Yeah, absolutely. So let me ask, you have a patient who has, unfortunately, high visceral disease, high burden of visceral disease, and has a hormone-positive disease, has a PIK3CA mutation, had received neoadjuvant therapy, and had a recurrence, unfortunately, shortly thereafter. You are looking at giving them T-DXd plus pertuzumab. How do you talk to them about this? What is your approach? Do you put maintenance into that strategy?
So what I would say is a patient like you described would obviously be very disappointed to see that they're dealing with recurrence after going through treatment in the early stage setting, and obviously may need some encouragement that our therapies in the metastatic setting are now very effective, and especially triple positive patients tend to do very well for many, many years. So I think a lot of the conversation first off is just in reassuring them that their disease is very treatable and that we have very effective therapies. The situation you described makes it very easy for me to choose T-DXd and pertuzumab in that setting.